So if you have a stone in the gallbladder, acute cholecystitis based on the clinical suspicion. Yes, you got fever. Yes, you got pain. Your white count's high. You go squeeze and the patient jumps. What is that called? Positive Murphy sign, right? So you get a positive Murphy. So when you suspect acute cholecystitis, what's your next step? What's your first step? Ultrasound. Why are you doing ultrasound? Because it is a imaging diagnosis. Why are you not going to treat? Why do you need the ultrasound for? You do an ultrasound, what are you looking for? 3 things. 2 I like, 1 I don't like, huh?
The Murphy's.
That is the one thing I don't like. So I'm going to put Murphy's sign below, last, okay? So, gallbladder wall thickening, right? Gallbladder wall is thick. And then pericholecystic fluid. Cholecystic fluid. So I said 2 I like, 1 I don't like. Why did I say that? Which one of this can you all fake?
Murphy's.
Can you fake a gallbladder wall to become thick? Can you create fluid around your gallbladder? No. But if you put a probe and you're touching your gallbladder, I can go, oh, you know, just because I want some pain med. So you can fake it. So Murphy sign being positive doesn't mean anything to me. You know what I mean? But a thick gallbladder wall or pericholecystic fluid tells you, yes, you have acute cholecystitis. So if you have this finding, then you got your diagnosis. Say you do an ultrasound and the ultrasound is negative. Then what? What are you going to do now? Because still, your clinical suspicion is present. Your imaging is not telling you that the patient's got acute cholecystitis. High-risk scan. So let me ask you this. Can you do a CT scan? Yes, but which is more sensitive? I'm comparing an ultrasound versus a CT scan. Ultrasound is actually more sensitive for acute cholecystitis compared to a CT scan, right? So ultrasound first. If that is negative, your next step is to do a high-risk scan. What is a high-risk scan? Okay, so once you diagnose somebody with acute cholecystitis, right, we do all these steps to diagnose them. How do we treat it? What's the number 1 thing you want to give? For acute cholecystitis?
Antibiotics.
Okay, good. Antibiotics. Does everybody with acute cholecystitis get antibiotics?
Yes.
Is acute cholecystitis actually an infective process? Or is it because a sterile gallstone trickled down and blocked the opening and now everything's collecting, causing back pressure, and that's the problem? The actual answer is that. That's the problem. It is not an infectious process, but they are very high risk of developing superinfection. And therefore, yes, there are some patients who are very mild that does not require antibiotics, but for most practical purposes and for the exam, yes, everybody needs antibiotics. Okay? So pretty much everybody's got antibiotics. Now here, you do not have to use carbapenems. You can use anything that would cover your gram-negatives and anaerobes. Any GI, gram-negative and anaerobes is what you want. Right? So you can use ceftriaxone, flagyl, right? Your levofloxacin, elmetro, ciprofloxacin, metronidazole. You can use piperacillin, tazobactam, anything that covers gram-negative and anaerobes you want to use here. Okay? So antibiotics, what else? Fluids, right? What else?
Interval cholecystitis.
Interval cholecystectomy, right? The board question answer, if somebody comes with acute cholecystitis now, when should you remove the gallbladder? Within that hospital admission, okay? Before discharge. Same hospital admission. Typically, same hospital admission. You want to get that gallbladder out, okay? Now, say the patient's here and got acute cholecystitis, calculus cholecystitis, and the patient is really sick, becoming septic, okay, requiring some pressors, and the patient is much sicker, right? In those patients, you don't want to go take them for surgery. So what would you do instead? You would do a cholecystostomy tube, okay? Cholecystostomy tube. You put a cholecystostomy tube to drain it, and you leave the tube, because most important thing when it comes to septic or septic shock is source control. Get the source under control, give them the antibiotics, and then do interval cholecystectomy. Even though real life we end up doing gallbladder removal much later, for the boards, that same hospital admission, you want that gallbladder out. Non-opioids basically, okay? Just give them non-opioids as much as possible. Okay, so now that we've spoken about all the structural problems that can happen. Now we are going to go to the zebra questions, the one where the 99th percentile people get the answers right to. Okay? So now, imagine a patient. I'll give you a 60-year-old female. Comes with vague abdominal complaints. Okay? Vague abdominal complaints, and she's very itchy. She's very itchy, and she's also got, so I'm saying 60-year-old female, itchy, and she looks yellow. Okay? And then you get labs. What would you see on the labs? What did you say?
Sorry.
T-bills.
It's a transfer.
T-billy is, total bilirubin is elevated. What else? ALP is also elevated greater than 1.5 times the upper limit of normal. What are you thinking? What are you going to do at this point is the first question. Okay, so you want to image the patient first because obviously, clearly this patient looks like there's a biliary obstruction, right? So the first step you're going to do is obviously do an imaging, maybe CT scan, ultrasound, maybe even an MRI. If it shows absolutely nothing, meaning there is no obstruction whatsoever, why is the bilirubin up? Why is the patient having elevated ALP? What do you think in this patient? You think of primary biliary cholangitis. It was called primary biliary sclerosis before, but now it's primary biliary cholangitis. Okay? Now, when you think of primary biliary cholangitis, what is it saying is you are having intrahepatic ducts that are actually getting destroyed. That's why you're not really seeing it on your large imager, right? So, how do you diagnose primary biliary cholangitis? What's your diagnostic step? What are you going to check for?
Antibodies.
You're going to check for antibodies. What is your antibody you'll check for? Anti-mitochondrial antibody. Do you feel good knowing that answer? You should.
Yes.
You should. But what if that's negative? What if anti-mitochondrial is negative? What do you check for then? Two other tests. Now, if you know the answer to those two, you should really feel happy with yourself. Anti-mitochondrial,
It's not smooth muscle.
No, it's not smooth muscle.
SP something.
Yes, it is.
It's like the.
You check for two antibodies, which is anti-SP100 or anti-GP210. Those are the two antibodies you'll check for. Okay, it's either anti-mitochondrial. If that's negative, next step, SP100 or GP210. Okay, now most of the time they'll be positive and you'll get your answer. If that also does not give you the answer, then what? What do you want to do? You want to do liver biopsy. Because what you're worried about is primary biliary cholangitis. Is it bad to have primary biliary cholangitis? Yes, because the liver can fail and patient can die. How do you treat it? You will treat them with ursodeoxycholic acid. Okay? That's how you treat them with. Now, why is it important? Does primary biliary cholangitis cause more problems apart from liver failure? And sepsis and dying? What else can it do? Does it increase the risk of cancer? It increases the risk of liver cirrhosis. Okay? Liver cirrhosis and hepatocellular carcinoma. That's what it increases the risk for. Okay? Now, that's done with that condition. Now, what if I told you not a 60-year-old female, but a 40-year-old male? Boys, don't feel like you are going to be left out.
With Crohn's?
Well, maybe not with Crohn's, but a 40-year-old guy is coming with complaints of abdominal pain, and he's also got a cholestatic pattern, elevated bili and elevated ALP. Okay, and when you do imaging, so if you have a person like this and it looks like a cholestatic pattern, right? And say you do ultrasound, CT, everything looks fine. There's no obstruction. What are you suspecting? Primary sclerosing cholangitis. Okay? Primary sclerosing cholangitis is what you're going to look for. What is your diagnostic step to diagnose PSC? Huh? Yes, you will do an MRCP here, and what you're going to look for is a beaded pattern. Okay? Your biliary structures are going to have a beaded appearance, and that's going to give you your answer. If you don't see that on MRCP and you still suspect it, How are you going to diagnose?
Also bad.
Liver biopsy. Okay, you will do a liver biopsy. Why is this condition so important?
Carcinoma.
It increases your risk of about 4 cancers. What are the 4 cancers? Number 1, primary sclerosing cholangitis is associated with ulcerative colitis. So the moment you diagnose, if somebody's got ulcerative colitis, after how long should you screen them for colon cancer? 8 years after diagnosis of ulcerative colitis, you will screen them for colon cancer. If you have primary sclerosing cholangitis, you do it now. Now, the time of diagnosis of PSC, you have to do a colonoscopy looking for colon cancer. That's how dangerous it is, right? What other cancers can it cause? So it causes colon cancer. What else does it do?
Cholangiocarcinoma.
It can cause cholangiocarcinoma. What else? It can cause hepatocellular carcinoma. So cholangiocarcinoma, hepatocellular carcinoma, and colon cancer. Okay? Those are the cancers that's associated with primary sclerosing cholangitis.